This is the Aware Families Podcast, the show that brings you a science-based, practical look at how to use the principles of functional medicine to keep your family healthy. All right, welcome back to this episode of the Aware Families Podcast. I'm your host, Tom Flass, and I'm here with a special guest, Dr. Reed Thompson from Kalispell Kids, with two Ds, as I corrected myself on that last one, Pediatric Dentistry, a local pediatric dentistry office here in the Valley. So welcome, Reed.
Well, thank you. Yeah, it's a pleasure to be here.
Yeah, I think the last time I saw you was actually at the Kids Triathlon.
That's right, yeah.
And you guys are sponsors of that?
Yeah, we sponsor that.
So it's a really cool event that we have here in Kalispell. Forget it, like 150 kids or something like that?
Yeah, over 150 kids this year, so yeah.
Different really age categories, so it gets them their first little taste of doing a triathlon, a little swim, a little bike, a little run. You know, it's a great event. You know, it's kind of a half-day event, and really it's good turnout. It's really cool seeing all that. So,
it's awesome, yeah. I mean, the kids have so much fun, and the adults definitely enjoy getting involved as well.
Yeah, and it's been going for how many years now?
I think they said about 15 years, something like that.
Yeah, that's awesome. Yeah, we've done it. We were out of town for one of them. I think we've done the last 5 minus the one that we're out of town for, and so the kids really look forward to it.
Yeah, it's pretty awesome.
So anyway, tell us a little bit about yourself. You know, what you do, what your background is, education, all that fun stuff.
Yeah, I'm a pediatric dentist in Kalispell, and I initially went to dental school. Went 4 years of dental school at University of Minnesota. And then decided to take an adventure up to Alaska. Ended up there doing public health dentistry. So I worked for the Public Health Service in Dillingham, Alaska. And
where's that at?
So it's about 350 miles west of Anchorage.
Okay.
So out in the bush. So it was about a town about 2,000, and then we were kind of the hub of kind of a larger area that was about the size of Ohio that we went out to. There's about 25 villages that we went out to and treated kids, and primarily kids, but then took care of adults as much as we could when we were out there. So
it must have been a completely different experience because obviously a lesser served population. So
absolutely, yeah, it was. It was a great experience as a new dentist to get out there and see the disease process in different locations than a inner city, but seeing in a very rural area was certainly quite an experience. And then to be able to travel out to different villages, we go out to villages and stay for a week at a time, treat kids, and then come back home.
So are you taking like a little float plane out, or
we didn't go on floats, but we do on small like aircraft, and then fly out to the villages. Needed to have a runway for us to fly into there, and then we'd base out of the school usually and take care of kids. So yeah, it was a great way to start out being a dentist, for sure.
I'll bet.
I never thought that a dentistry could have such an adventurous aspect to it. So
very much so. And I always think there's, in some ways, an interesting crossover between Montana and Alaska. And there's a lot of people that have lived in both. I think there's we have some, maybe not as extreme of the rural, but we have some pretty rural, small town type of things. And so I think it's that you get that mindset in that's very different than like a coastal big city experience.
Absolutely. And I think a lot of those people are just not afraid of the weather that sometimes comes along with living in Alaska and Montana.
Yeah. And the long, dark
Absolutely.
phase and stuff like that. We're like tropical, I think, probably compared to as far as the light goes, although it's starting to get darker these days. It's amazing. The farther you get away from the solstice, and all of a sudden you're like, oh yeah, we're heading back to the dark days again.
Yep.
But not quite yet.
I think for me in sleep, it probably actually helps me out.
Yeah.
I don't mind this.
Not that manic thing, because where you were probably getting in the summer, like the peak of the summer, you were probably getting like, only like 4 hours of that sort of half light, not even full darkness.
Yeah, exactly. And I mean, it's hard to go to bed when the sun is blazing and you're getting a sunburn outside at midnight.
Yeah.
And so it's pretty hard to.
But the positive side is you can go fishing at midnight, and people do
fish all night long,
and people do.
And then after that experience, I decided to venture into pediatric dentistry. So I was certainly treating a large number of children there. About 75% of our time was spent treating children, and then went back for residency at University of Minnesota for 2 years, and then became a pediatric dentist and decided to come back home to Montana.
And so when did you start Kalispell Kids?
So we started Kalispell Kids. We took over in 2009, and so yeah, it's been a fun adventure. My wife and I decided that maybe we'd try out private practice with certainly a public health mentality, just because I think having that as experiences has allowed us to try to develop something different. Running a business has certainly been the challenge piece of it, but it's been nice having those experiences and understanding what the disease process looks like at a very different level than I think we accumulate just during dental school and residency.
And at your clinic, it's all kids, right? It's just kids, so which
Yeah.
is obviously different than some that will do both. And certainly having been there, and my kids go there, and the experience when you walk in and just the layout, and it's a kid friendly environment, to try to take away the fear the fear factor and make it a more comfortable environment for kids to go in.
Yeah, and certainly that's the goal. And our goal is for a child to walk into our clinic and realize that, oh, this is not just a medical or a dental office. This is a kid-friendly environment, and everything from countertops to be low enough that they can see over, and so they know who's behind the front desk when they're checking in, and everything from the moment that they make that first phone call to our front desk. We are very comfortable seeing kids all the way down to a few months old. So,
yeah, a very different, like I said, different experience, different mindset. Having gone through the whole process for you, like what do you feel are the big things that set apart like an environment or the practice like that, like pediatric dentistry? Because obviously it's sort of like in myself being pediatrician, pediatric GI, it's like kids aren't just little adults. It's always the mantra we had, training and stuff like that, which I think sometimes gets lost in the shuffle. But, from the dentistry aspect of that, the kids aren't little adults. Like, what are some of the things that you feel like sets it apart?
I think really it's developing a team that has that desire to, because I think all of us can kind of say, oh, we love kids. But it's very different when you're in an environment where you're putting them in a situation where sometimes it's not maybe all comfortable things, but really trying to find that team that you can gather around that has that same goal to give kids a positive experience. And certainly when we start seeing kids at a very young age and they start to realize that, oh, this isn't always a difficult place to be. It doesn't necessarily give them a negative feeling about it. And I think that's for us is that when we especially hear parents that look at us out of the corner of their eye and say, wow, my kid was really excited for their dental appointment. Something that we don't expect.
I'll take things you never hear for 1,000.
Yeah. So those are the rewards. And like I said, just developing that team that has that desire to work through the process and
make it a good experience.
Absolutely.
Yeah. So 10,000 foot view, what would you say that the state of the union of kids' oral health these days?
Well, as much as we'd like to think that it's everything in this day and age that we have things figured out, and we do understand that for number one, I mean, the number one issue that we deal with kids is certainly cavities, and of course
still, which has been the case for.
Yep, ever since sugar has increased in our diets, that's certainly been the case. And when we look at kind of age groups, I mean, right now in our country, about 25% of kids 2 to 5 years old are actually experiencing some kind of caries. So that's the disease process.
So
that
1 out of 4
cavities. Yep. And then when you get into the 6 to 11-year-olds, it's up to 50% have actually experienced a cavity. So certainly we have a lot of work to do, and the thing is, dynamics are always changing, whether that's parenting styles or how we're eating, different oral hygiene activities. I mean, certainly there's a lot of things that just are constantly changing, and we have to kind of roll with those changes and try to figure out how we can
see what the societal trends are and try to outflank them.
Well, and some of those are so embedded. I mean, for so many generations.
And we'll definitely dip into this, as we kind of go. And you and I have had conversations about this too, like the cringe factor of like the standard American diet and some of these other practices going on in the school. So we'll kind of talk about that too. So, I don't know, and that sort of segues, I guess, into the next question. Like, what do you feel like right now, with the way that trends are going, are some of the biggest hurdles to good oral health in kids?
I think for us to, again, continually to reevaluate as we said, societal things change. We want to make sure that we're kind of shifting with those changes, because there's so many dynamics. And I think, kind of basically, I think a lot of people are aware of, okay, what are the worst things for our teeth? I don't think we really have to speak of those as much anymore, because I think everybody knows that popping candy cause cavities. I think that's been pretty well established.
You'd be surprised. There's a level of denial sometimes, that.
And I think what it is that we've modified our soda or pop and candy. I think that's what's shifted, is that there's been this trend that just is changed in the dynamic, that it's kind of a lot of hidden things out there, and people don't think of those because those phrases or those words aren't used for those.
The juice,
Yeah.
There's that factor of it, and then and the hidden sugar, right? The added sugar.
Oh my gosh.
Yeah. Which, having been lucky enough to do some work with Dr. Robert Lustig, who is, I don't know if you go back and look on YouTube, he has this video, it's probably like at least 10, 15 years old now, called Sugar, the Bitter Truth. And he's a pediatric endocrinologist out of UCSF, and, did a lot of the early stuff on like metabolically how bad sugar was and how much it was like sneaking into the diet, and kind of took on, and still is taking on, the sugar industry, which is a big, as you know, a big industry.
Well, and I think that's, as you said, what is the hurdle? I think that's the big hurdle, is that for all of us as a society to start relooking at those things, because, it's a difficult, daunting thing to take on those big industries, because it's so embedded into it for so many decades, and then trying to help that shift to not continue going down this path of just increasing sugar, because that's what sells.
And there's over 100 names for added sugar, so they make it difficult sometimes. I mean, they do technically by law have to state grams of added sugar on the label, although they've been trying to shift and get around that to some degree. Because if you look on the ingredient list, I mean, sometimes it will say sugar, but then it'll be like, there's sugar, there's corn syrup, there's high fructose corn syrup, there's fructose, there's all these other things.
Or maltodextrin. I mean, it's
a lot of different things on there. The fruit extracts, or the fruit, some of the fruit concentrates or fruit juice concentrates. That it's natural, but it's still sugar.
So one of the more recent ones I think I saw was monk fruit extract.
Yeah, which I have to do a little more research on. With some of these, that are sort of non-caloric carbohydrates, like the sweeteners, anything from like stevia to monk fruit to the allulose to erythritol, maltitol, sorbitol. And I know that like from an oral standpoint, like the sorbitol and things like that are not, they're not damaging, and they may actually have some kind of benefit. I don't know what your take on that is. Some of those, they call them alcohol sugars.
Yeah, I think the number one that we see in dentistry is xylitol, so that's certainly something that is considered a natural sweetener, I guess, because it's been derived from a plant. But that just kind of seems to be a gray area when you start to make things into powder. But essentially xylitol has been looked at quite a bit because it does simulate a glucose molecule, and so the bacteria do see it as glucose, but they can't produce energy from it.
Okay.
And so they have to spend energy to get rid of it. And so there has been some studies. The challenge is that when we look at the trying to prevent the outcome of caries or cavities, the challenge is that it does seem that you have to have 6 exposures a day, 5-minute exposures for 3 months to see a decrease in cavities. And so it's a pretty significant amount. And
there's gastrointestinal effects from a lot of these. If anybody who's had the keto type of products, they're like, no grams of added sugar, and you're wolfing it down. And as you get more and more bloated, you're like, huh? And you look on the label and it's got, tons of erythritol or whatever in it. And
Yep.
there's people whose systems, including mine, do not tolerate some of those things at higher level. Or if you eat too many of grandma's diabetic candies,
Yeah.
many a person has experienced that, the sorbitol or xylitol or whatever they're using in there. It's, it's not a digestible, but it is a fermentable
Yes.
carbohydrate. So under that whole FODMAP thing, which we've kind of talked about too, it does a number on some people's GI tract. So maybe
Absolutely.
a little kinder to your oral health, but not necessarily so kind to your lower gut microbiome and all that fun stuff.
Well, I think that's the challenge, is that we're just always looking for the easy fix. Mm-hmm. That's what people are hoping for. I want the sweet flavor, but I want the low risk, and it's sometimes not that straightforward, just because something is natural and we've come up with it. And 6 times a day, brushing twice a day for 2 minutes can be challenging for people, mm-hmm. let alone trying to target something like that, as you said, can cause a lot of other GI issues.
Mm-hmm. And maybe alter the gut microbiome in a not so favorable way, which we're just, starting to study now. So yeah, there's always, look downstream and see, see what the other possible effects are. Run us down real quick. What's the sugar and dental caries or cavities? What's the link there?
So essentially what it is that we need to have bacteria, and the bacteria that cause cavities is essentially Streptococci mutans. And so essentially that's the one we're looking at that does use sugar. As it uses the sugar, it processes it, and then once it processes it, it creates an acid. The acid touches the teeth, and that's what demineralizes the tooth. Mm-hmm. And so that's the link to where we know that sugar is the key element that has to be required for cavities to develop. And
it's we were just talking about this before we started recording. Is that it's not just, sugar is obviously the worst perpetrator, but those super processed carbohydrates, what they call like ultra refined flours and stuff like that are starch, which is essentially a bunch of like sugar molecules stuck together, that may be almost as bad, like the ones that get crammed in your teeth.
Yeah, like you said, starch is just a whole bunch of glucose molecules linked together. And so, as you were talking about the consistency of what that looks like, because the fish crackers, I think, are the one thing that we see that's very common. Mm-hmm. And if you ever look in, or if I eat it, I feel it in my teeth.
Yeah.
It sticks to your teeth.
Well, the kid will smile and you can see it like just crammed in all those nooks and crannies.
Yep. And oftentimes we have parents that come and say, why is there orange on their teeth? And you can kind of put it right back to those dyes that are in there, mm-hmm. which when it gets crammed in there and stuck in the grooves, certainly that's a key element to
because we know there's actually enzymes in your saliva that, and that whole experiment that sometimes kids do when they're young, and like you chew a cracker and then hold it in their mouth for a couple minutes and then it starts to taste sweet.
Yep.
Because you're actually breaking down that starch into glucose in your mouth,
Exactly.
And so if those little wedges of ground up cracker bits or, flours jammed in there, that process is happening, right?
Absolutely. Yep.
Which is not that all starch is bad. I'm not trying to say that, but that ultra processed stuff that gets jammed in there, and especially somebody who's not brushing and, getting that stuff out of there, the longer it sits.
Yeah. And it's that balance is that, brushing, but who's brushing right after they eat a whole bunch of crackers? That probably is not the most common thing we see in our society.
Yeah.
Certainly, we have this habit of brushing in the morning, brushing at night, but it's all those in-between times that those things that start to affect cavities are obviously being put in the mouth all day long, and that's what the big concern is that really looking at some of those frequencies of when we do eat those things and then balancing out how often we brushing them away.
So, and again, we were talking about this right before we started recording, but let's talk a little bit about like how early does this process start, and we talked about bottle rot and explaining what bottle rot is and how that sort of translates into as these kids are cutting teeth, and how early this whole process can get started.
Well, we do understand that we are not born with the bacteria that cause cavities, and so essentially that has to be accumulated somewhere in early childhood. The link is certainly the people that are around the closest to us are the ones that are going to probably expose us to that bacteria. And so that would be, of course, mostly parents, and then also siblings. And so as an infant, before they have teeth, they have to get exposed to that bacteria. Once the teeth do start to erupt, then that bacteria can start attaching to the tooth. And so that's the first piece of the puzzle, is kind of looking at what is that exposure to the bacteria around children. The window of infectivity is between 0 and 3 years old. And so that's when we kind of target that time that says, okay, is that bacteria available? And that could be, I'm demonstrating feeding to my child, and I'm eating off a spoon, and then I'm putting that spoon in their mouth. And if I have cavities in my mouth, I'm starting to inoculate them with that bacteria. And then, and I don't think it's going to happen. It's not going to be one time. You're going to put it in there and it's going to be all over. It's really just that number of times. And so certainly we kind of talk to parents about what is their risk for cavities? What is the siblings' risk for cavities? What does that look like? And then when we have that infant, we can kind of talk to them and say, well, is there a way we can try to minimize that transfer of that bacteria? Because we do know, I mean, much like you were into the gut biome, what gets established in there is going to either create health or create disease.
The first 1,000 days
exactly
also include that, conception through age 3, essentially. It's such a huge time for so many things: gut biome, oral microbiome, oral health. It's just tied in. So yeah, that's fascinating. That ties right in with that. So what about? Because one of the things we're discovering is that mom's gut microbiome impacts. Like, there's actually a breast milk microbiome. And the body is amazing, and it will in some ways sort of detect if there's something that the baby needs, and be able to take certain bacteria, I think, out of her gut and put it out through her breast milk, so that there's like bifidobacteria and lactobacillus and other things getting sort of passed on. But I wonder how that works. Like, and I don't know if that's been studied at all. Could they be getting the strep mutans through breast milk? Or is it a separate process, more like you said, like food sharing, or siblings or other exposures like that? I don't know if that's ever been looked at. I haven't really gone.
Yeah, I think most
deep.
of the evidence is based on that direct transfer of the bacteria. But certainly that's interesting to kind of imagine how all those things are interrelated. Just because, I mean, if it's happening in the gut, and I think that's what you and I have talked about a lot, is that it is not separate. I mean, it's one system, right in through the mouth, out the other end, and it is all one system. So I think we're starting to kind of close that gap and realize that there are a lot of similarities in those things.
Oh, and kids and adults, and in functional medicine, we're all in on this. And I've talked to your dental group, and and it seemed like there's a lot of really forward-thinking dentists in the Valley, which is great, because like this is not being talked about enough for adults. That link between oral health and risk of heart disease, risk of Alzheimer's. I mean, there's direct links, and that if you have inflammation in the mouth, it's not staying in the mouth. Like, it's affecting the whole body and negatively affecting the gut microbiome and leaky gut and all these things. So yeah, exactly. Like, it's all interconnected. But I think there's still like this is the mouth stuff. This is the body, like almost like it's a separate being or something like that, which is clearly not the case.
Well, and I think in our country, it's been divided out. If you think of the insurance piece, you have dental insurance and you have medical insurance. I mean, we've just separated so many things out that now we're starting to close those gaps and realize that, okay, it is all one body. And it's pretty fascinating, all the new studies that are coming out that are linking so many of those health concerns. I mean, the big things that kill our people, kill humans in the U.S. are
being linked back,
linking back to some of that inflammatory process and even the bacteria. I mean, those are the two pieces that they're kind of looking at, is that atherosclerotic plaques do show oral bacteria in them. And so we're trying to figure that out to say, okay, there is certainly some links.
Yeah, and when they biopsied Alzheimer's brains, what do they find? They find the same bacteria that causes gingivitis, that with like inflammatory kind of plaques and other things around there. So there's strong interest in this, and now it's actually fascinating where we're starting to be able to do oral microbiome testing. There's like these test kits, that I know we can order it through one of the lab companies that we've done. I haven't really gotten too far into that yet, but I've been listening to some podcasts, and, I don't know if do they talk about that type of stuff at any of the conferences you go to, or I know it's kind of a pet interest of yours.
Oh, absolutely. And I think the challenge is that it's the location of the bacteria, and then how is the best way of testing it, because certainly we're seeing that different times of day testing plays a big role in it. So in the morning is different than after you've eaten, which is different. So just actual saliva testing is challenging just because it isn't consistent for humans throughout the day.
Yeah, it's like hormone testing,
Yeah.
You got to do it at the right time and consistently to be able to compare apples to apples.
Absolutely. And then how it's layered. I mean, even we do understand that how bacteria is layered, even in the oral cavity on our teeth, that plays a big factor in it.
Biofilms.
Yep, exactly.
Which again goes on in the gut, goes on in the mouth, and it's hugely important in the mouth, right? Because if those bacteria, so biofilms are like a slime layer, right, that the bacteria produce to protect themselves. And if you don't disrupt that biofilm, those bacteria hunker down, which I think speaks to the brushing and flossing recommendation is like, and we'll talk about that in a second, what the kind of recommendations for kids versus, as they get older and when that transition is. But breaking up those biofilms so you can get at those bacteria and get them out of there, or at least knock them back a bit.
Absolutely. And like I said, that layer, because not all bacteria can stick to the teeth. It takes certain bacteria to stick to the teeth, which then other bacteria can attach to, and so it's such a complicated thing. And so we certainly can do some saliva testing, and you can look at some of those things, but certainly when you're trying to identify dental disease, that's the challenge is that, how is that layered on the tooth? Mm-hmm. So just looking at saliva content gives you a piece of the puzzle, but it might not be good information as far as, okay, is that going to really truly tell us risk of cavities?
Yeah.
I've even done one of the tests myself. I actually didn't brush my teeth for 4 days and went and did a test to see.
You were
in
a room by yourself, your family
I wasn't.
shunned you.
I actually showed up at a clinic, and they swabbed me, and they had a huge amount of bacteria in my mouth, and it was dramatic. And so I fortunately had some kids with me, and I asked them, I said, do you think that I must have a lot of cavities? And they're like, oh, yeah, you must have a lot of cavities. And I fortunately have never had a cavity in my life. And so it's so just looking at a number is a piece of the puzzle. We don't need to ignore it, but it isn't giving us the whole picture of kind of what that looks like. But I mean, there's no doubt about it.
You probably also weren't subsisting on candy and soda for those 4 days either, which would also be another interesting experiment, right? Like really go on the standard, really like bad end of the spectrum, standard American diet versus more of a Whole Foods,
Absolutely.
a Mediterranean type of diet. And I know they've done some of those experiments, and there's dramatic shift in gut microbiome and I think oral microbiome within days.
Absolutely. And then the other thing we can't ignore is that saliva. I mean, we have different saliva. And so, of course, that's going to make up a large portion of when they swab your mouth is that you're getting that saliva. And that's where the different times of day can play a big role in it. Mm-hmm. And then your buffering capacity of saliva. I mean, some immune system factors and all those can't be ignored. So it's not as simple as it seems like it should be, like on TV where they just swab somebody's mouth and they get all this information. It's a piece of information, but like I said, we're developing a lot of new ways of trying to unravel that to see if we can get
It's always more nuanced,
Absolutely.
Yep. So, and I don't know if you know this, but I think it's in line with this part of the conversation is, obviously in younger kids, we're worried about cavities, dental caries. And then as we get older, at some point, gum disease becomes a bigger issue. Like in your opinion, when do you think that sort of transition when we're less worried about cavities and more worried about gum disease? Because obviously gum disease as we age is a huge issue.
And a lot of it for kids, as you said, it's mostly caries that we're looking at, and then gum disease kind of sets in later, which some of it kind of makes sense in the respect of if you think of when we're younger, we have a lot of cells that are building bone that are doing a lot of things, so we kind of have that benefit of even with not great oral hygiene, the body is better at kind of managing that. When we think of gum disease, which certainly kids can have gum disease, which gingivitis is probably the most common that we see, and essentially that can set in just within a few weeks of not doing good oral hygiene. And then when we think of gum disease into adulthood, that's where we're kind of thinking of something called periodontal disease, which that would be actually bone loss around the teeth. And so that's that shift that kind of happens. The studies have shown that, they kind of look at kind of 30 and older is kind of when we see that. And the latest statistics show that 42% of people over 30 years old in our country have periodontal disease at some level. And so certainly...
Which that's a frightening statistic, knowing the links with heart disease, Alzheimer's, all these other, pro-inflammatory conditions. Like, that's no joke.
Absolutely. And that's a lot of the reason that we're kind of targeting kids to, start those oral hygiene activities really early, which if you're looking at cavities, certainly you're targeting brushing. Because there's no doubt about it, in brushing with the fluoride toothpaste for 2 minutes, there is a large amount of science that has shown that does decrease cavity rates. Flossing is certainly important. It does remove the plaque. When you look at actual cavity rates, there's mixed science on flossing, whether that is how big a factor that is, but our goal is to get those kids understanding that's part of the oral hygiene activity, because that's what we're targeting, is that later in life. Periodontal disease, there's definitely more
then flossing becomes increasingly important the older you get.
Yep, exactly. So.
And still not on a lot of people's routine list or whatever to try to do that. But so I imagine then probably the recommendations in your mind would be like, as we kind of get through the teens into 20s, you're trying to establish that flossing habit. Because as we get through our 20s and into our 30s, that risk of gum disease going up, then the flossing becoming increasingly important.
Absolutely. And I've always said that I think, our lives are so dynamic in those early years. And I mean, it's different for each of us, but I always feel like that when you think of what's your potential of disease process of getting cavities, I think that fluctuates all the way into your 20s, mid-20s, maybe 30. And so once you get to that older age, you probably have kind of established what that risk is as far as cavity rates. But it's that periodontal disease that sometimes sneaks up on people, because we do know the bacteria don't get along. So you don't often see people with high cavity rates and then get serious periodontal disease, because of the fact that those bacteria just don't get along.
So the P. gingivalis and the strep mutans are duking it out.
Yeah, they're just not getting along real well. And it's not to say it doesn't happen. There's root caries that happens as you lose gingival attachment or gum attachment around your teeth, and so we will see some different dynamics that change that. But in general, and that's what we always tell people is, we're low risk for cavities. Don't forget that could mean that you have that more of that bacteria that is more likely to cause periodontal disease later. And again, like you said, with all the evidence is starting to develop.
Don't ignore it. And I always say, like, a dentist is a crucial part of your healthcare team, and especially one that a dentist that is more kind of holistic minded, and nutrition savvy and isn't handing out candy bars and and suckers and or maybe you're driving up your own business, right? Like I thought that was ironic when you're younger, like, come get a sucker after you had your dental visit. Like, wait a second.
We've definitely gone away from that, and certainly there's so many times that I struggle with that. I'll go to a dental convention and a big cart of soda will come out at lunchtime.
Yeah.
And I just have to sit and look at this and say, and that's the thing is that we're talking about, is that society just has this piece that is driving so many of our decisions that we're making, and certainly the marketers out there, are trying to push their products.
And where the, a treat once in a while becomes then the daily dessert, or, giving candy as rewards in school, which I have a bit of an issue with. I know I'm a Debbie Downer on that, but it's when you step back and you look like, what are we trying to do here?
It's and that's oftentimes when I have a teacher in my clinic, I have those conversations, and I think it's important for parents to have those conversations. And I always kind of relate it to the fact that, having a piece of candy for every kid in the classroom is not going to cause cavities in every kid in the classroom. But because every child has different experiences at home, has different frequency of things, it is promoting cavities in at least some of those kids.
Mm-hmm.
And certainly, just from the whole addictive end of sugar,
Mm-hmm.
I mean, that's a whole nother dynamic there. But it certainly is, and it makes sense why it's being used. I mean, teachers have more challenges now, or different challenges than they've had
Absolutely.
in the past, and so trying to find those ways to motivate kids, and it's really cheap. I mean, candy in our country is incredibly cheap,
Mm-hmm.
and it is very low
Because we're
cost
subsidizing
way.
it.
Yeah.
It's being subsidized.
Yeah.
Our tax dollars. Which, that's a whole nother rabbit hole we won't go down today. But
yeah.
So on that note, with the kind of dietary progression, because it's not just, not feeding the cavities. Oh, and we're going to talk about bottle rot. Like, what is bottle rot? When do you see it? What are the risk factors for that?
Well, I'm glad we came back to that, because that little diversion there is really good. But getting back to, so when those first teeth get established, that bacteria is starting to become established. And nowadays, bottle rot is referred to as early childhood caries. And so essentially we identify that just depending on the severity of it and kind of how early that is. And really, once that bacteria is exposed, that's not the end of the world. I mean, we can get that bacteria. So the cavity-causing bacteria is an infant, but it really comes down to how is that fed? Mm-hmm. And so I think that's the key element that we all need to always be re-looking at, especially not just in infancy, but as kids get a little bit older. Pretty soon dynamics change. I mean, we just talked about sugar in the school, and it's one of those things that dynamic is always changing. And so I think we always have to keep focused that, okay, now my child's 2, I have all this control. Now my child's 6. Now my child's 11, and how do those dynamics change? Mm-hmm. But essentially, you have to have the carbohydrates available to that bacteria to start to develop that biofilm. Mm-hmm. And so how we're feeding those kids at those very young ages is so critical, because on one hand, you can feed a cavity-causing bacteria, and that will grow really well, or you can be feeding other bacteria. And when that gets established on your teeth, you might become the age of 3, the end of that window of infectivity, and you might have a good biofilm. Mm-hmm. Something's going to grow there.
Yeah.
And just like the gut, if we get the right stuff growing there, that's a protective mechanism. Mm-hmm. And so that's the piece of the puzzle, is that the early feeding kind of experiences can make a big difference. And I think we're learning a lot more about even flavor, how flavors that are given to us when we're really young do determine kind of what our flavor development is. And
even in utero, even in the womb, what the mother eats, like the baby can, believe it or not, have a taste thing, and that those taste preferences. If she eats a lot of vegetables, they've actually shown this, the child is more likely to accept vegetables in that toddler area when you're introducing them. So you can kind of do yourself a pay your future self by eating healthy during pregnancy, introducing those good foods early.
Absolutely.
One of the things that used to give me the shivers, and I'm hopefully getting away from it, but culturally, we'd see this in Denver sometimes, where families would be putting soda in the baby bottle.
No.
Which I'm sure you've heard, maybe even seen stuff like this.
I've seen that, and I hate to say it, but I still see it. So it is still not uncommon. And again, looking at that flavor desires, as you said, when they show kids that are exposed to high amounts of vegetables early in life, become better vegetable eaters as they get older. And some of that is that flavor desire. And I think for all of us parents, we can kind of say that my infant probably didn't like strong flavors. Those strong flavors weren't desirable. But I think it's us as parents is that encouraging those, because,
consistency.
I like these things. And I mean, not to downplay some of the things that people really enjoy, but I mean, just think of like applesauce. Applesauce with no sugar in it is incredibly sweet. And we're not going to choke on applesauce, but giving kids that at a very young age how does that start to develop those flavors? So when that infant starts to have those things. So certainly when my little guy was very small, I even used your book as some of my guide, which it was a wonderful book, and I appreciate having that out there. And essentially just trying to target, vegetables, primarily vegetables at those young ages. And I would even kind of test my little guy and kind of say, okay, what if I tried something that was stronger flavored, more acidic, more sweet? And certainly you could tell that wasn't desirable at those young ages. And I think it's our parent influences that start to create that dynamic.
Lead by example.
Absolutely.
For part of it. And then just that consistency, repetitive. I mean, you talk to the feeding therapists or speech, the SLPs, and they'll be like, it takes 20 or 30 times sometimes. If some of those foods that aren't, only takes one time for a sweet food and they love it, but something like broccoli or whatever, it may take a handful of times, up to 20 times of introduction, and they're like, oh, okay, this is part of my gig.
Yep, this is the norm now. So, yeah, and just following that stream of that early childhood caries, or actually formerly known as bottle rot, is that when you kind of look at the different pieces of that puzzle, is certainly nursing has been shown to actually help develop good bacteria. And so we don't see that nursing is definitely the high risk, but as soon as other carbohydrates are started to add to the diet, that's where it does show that breast milk can encourage that bacteria to grow. And so that's what we kind of look at is like in that first year of life, when it's primarily breast milk, that has not been shown to be a high-risk time. But as soon as other carbohydrates get introduced, and then so that second year of life, if there's a lot of other carbohydrates in the diet and breast milk, it has been shown to increase that risk. And really it comes down to frequency.
Frequency, totally.
It's not that the breast milk in and of itself is there, it's just that frequency of it. So that nighttime feeding, I think, is
and that overnight bottle where sometimes they'll leave the bottle with milk or whatever in the crib, so that it's sort of in place of that dream feeding of breast milk, but that constant exposure on their erupting and developing teeth, because again that lactose sugar is glucose and galactose, so it still has that fermentable sugar, and I think that will somewhat break down in the oral cavity if left exposed too, right? Like
Absolutely.
that lactose will break down into the glucose.
Yep, it starts to break down immediately. The enzymes in our saliva, that's where the process all starts.
Yeah, and then the glucose is the party time for the for the strep mutans potentially. And again, like you said, it's the when and the frequency, because as Mother Nature designed, the frequency of breastfeeding typically goes down as the baby's weaned onto foods, 6 to 12 months. Again, I don't think there's a hard and fast rule, like you don't need to automatically wean off everything, by 12 months. And I think some of those winter babies, especially the immune benefits of continuing that some breastfeeding on through the following spring, I think has been shown to kind of decreased respiratory infections, hospitalizations, things like that. But it should be in conjunction with a good repertoire of added foods. And so I don't know what your thoughts on like the baby-led weaning kind of part versus or some kind of modified baby-led weaning. And we talked a little bit about this with our recent interview. But yeah, I want to hear your kind of thoughts on that, like food introduction and how that impacts not just the oral microbiome and stuff like that, but actual oral development.
Absolutely. And certainly when we look at those things, some of the things that we think about is kind of just chewing. Infants are wanting to chew. I think that's kind of at some point, as they get teeth, and as they get those teeth, starting to introduce things that actually promote chewing, which can change muscle structure, bone structure, a lot of those things, that has a whole additional dynamics that kind of down the path. And so we followed some baby-led weaning kind of philosophy with our child, and certainly it was interesting because I think the challenge is in our country, we've decided that we don't want kids to choke, which absolutely, we don't want choking, but we may have shifted for too long to one direction, and now everybody's concerned about that. So essentially baby food came out, and we came up with everything puree.
Everything's in a pouch or a
absolutely
puree.
And then now we have all that available there, and there's probably some societal dynamics that are new parents are trying to figure out how to unravel this, and of course trying to figure that out. But when we don't have that chewing ability, moving that jaw, starting to have more solid foods, not just drinking everything. I mean, even in adulthood, we're into this smoothie thing. It's like everything's a smoothie now, and that's how we're going to get our nutrition. But how does that change the dynamics of the food we're having? Whether you can probably speak to fiber content and size of fiber and all those things, but all those pureed things at a very young age certainly do decrease the risk of choking. But on the other hand, I think when we're trying to, safely train our infant kind of how to eat, start manipulating their jaw, start chewing, I think that's what we're going to come to the conclusion is that we probably can decrease choking hazards if we're safely introducing that at a younger age. And those types of foods that they're sitting and chewing on can be something that can decrease that risk for just the pure fact of cavities, just for the pure fact that the consistency of the food can knock things away.
Yeah.
Certainly we're using only the little puffed treats that are all
Sticking.
natural infant, meltaways, I think they call them.
Yep.
Certainly that is very low risk, but if you look at the side of them, it doesn't matter how natural it is. It's still piled full of sugar. And so, just kind of looking at, can I cut up a vegetable? Can I make a vegetable, maybe cook it a little bit so it's softer?
Yep.
And so that we can train that infant to kind of manipulate that food. Certainly, as baby-led weaning says, gagging and choking are two different things.
Yes.
Gagging is learning how to manipulate food. Choking, obviously, is not good.
Yes.
And so that's that balance that you're trying to unravel. And I think using those more solid foods at those younger ages. For one, what does that do for the infant when they go to bed? If they've had more solid foods, they don't get hungry as soon afterwards. And so then those nighttime feeding episodes can change as time goes by.
Yeah, and it's interesting, the whole Weston Price Foundation stuff where they've kind of looked at people eating indigenous cultures, whatever traditional diet, where they're eating chewy foods pretty early on.
Absolutely.
And it really changes their structure of their mouth, so their teeth aren't as crowded. And they've actually gone back, historically and looked at, teeth. You think people must have had teeth rotting out of their heads, as we evolved or whatever. But that was the opposite,
It was not the case.
They weren't eating any processed carbohydrates or sugars. They had beautiful teeth. They had great mouth structure. Their palates were wider, so they probably had better breathing, because that's a whole nother rabbit hole to go down, the whole mouth breathing thing that seems like it's an epidemic now, that we're starting to realize the negative effects of mouth breathing on the oral microbiome, on cavity risk, on all the kind of sleep apnea and these other kind of sleep disorders, which have a huge bit of downstream effects, which I think is people are just starting to catch up with the fact that this hugely relates in with dentistry and oral health on both sides of that equation.
Absolutely. And as we were saying, starting from infancy, that's where that's, starting to chew, use those muscles. Our skull is developing, bone has to have pressure for bone to develop, and all those dynamics are affecting things down the road, just because, there's no doubt about it. We're seeing, like you said, with a smaller oral cavity, that's obviously airway challenges. As you said, high palates. If we think of the roof of the mouth as the floor of the nose, that's all right there, and how we develop that can have a big factor as we're getting older, especially if we're starting at that infant and kind of thinking about those things, and how do those different factors kind of play a role.
And this is not a judgy thing at all, because my kids have both needed palate expanders because they're kind of coming in. It's probably some genetic component to that as well. But it's also interesting to think about the positive benefits of early recognition, use of palate expanders, not just to help those teeth come in and and if there is a need for orthodontia, that accelerates the effectiveness of all that, and then get a better results quicker, with the use of things like palate expanders, but also what potential positive benefits that can have on not being a mouth breather, having better airway flow through their through their nasal cavity, because again, like you said, that expansion of the floor, I think it's really interesting.
Yeah, breathing through the nose is huge. I think, and that's just, I mean, that end is developing so much. I mean, there's so much more science that's coming out that's kind of recognizing that. And certainly the biofilm changes in your mouth when you're breathing through your mouth.
Yep.
I mean, certainly, it can dry tissues out. I mean, we just see so many different things from the disease standpoint in the oral cavity. But like you said, I think the big thing that we're looking at is kind of that sleep piece, that breathing. I mean, certainly what we want to see. We want to see kids breathing through their nose, quietly, mouth closed. I mean, it is good sleep.
Yeah, because now the adult thing is like mouth taping has become a big thing and all this stuff like that, which I'm not advocating that in kids at all, but also recognizing, though, if they are a mouth breather consistently, that's something maybe to bring to the attention of, your primary provider and or your dental provider.
Absolutely.
Like what's going on in there that's kind of leading to this. And there could be a whole host of things as far as, chronic nasal congestion, undiagnosed allergies to, deviated septum to whatever. But like, I think the fact that it's like, this could create some downstream issues, recognition. Absolutely. And sort of some, again, deeper dive what's upstream of that, and what's downstream of that.
Yeah, and tonsil adenoid size, and how is that related to even the allergens? Just because you have large tonsils could be related to allergy issues. And so those are the things that we're trying to help people unravel, is to say, okay, how do you go down this path? Historically, I think it's always been, have your tonsils and adenoids out. And certainly, there's kids that absolutely need that, and certainly that is going to create a better airway. But there's a lot of dynamics there that we're trying to help people unravel.
Like those kids who have the huge tonsils also have recurrent ear infections and recurrent sinus infections, and then you take the dairy out of their diet, and it all gets better. I'm not saying that works in every case, but I've certainly personally had patients who are like that, or some other trigger, some other food trigger, things like that. So. Again, it starts. I would say all disease starts in the gut, but I guess technically you could say all disease starts in the mouth. And what you're putting in there,
is entering into the gut. So.
Yeah, it is. It's the entryway. It's the first deal there. What's your thoughts on, like, as far as fostering the good oral microbiome, like pre and probiotic foods? We talked about like just the fact of like chewing and having those the fiber and the what's called prebiotic fiber, which means it feeds the good. What's your thoughts on that from the sense of the oral microbiome and fostering good oral health?
So as far as from the probiotic end, I think that is our future. I mean, I think that is what we're certainly seeing as a target and there's probiotics that have already been established out there. I think we're kind of in the beginning phases of that and trying to figure out how to implement that and how is the best way of
introducing the good guys.
Yeah, introducing the good guys. But we can never ignore, like you said, the prebiotic piece. That it's like, okay, you can introduce as many good guys as you want, but I always equate your mouth like a garden. As you're feeding certain things, that's what's going to grow. And so that's what we're trying to look at is that certainly, is it required to do probiotics? We're not certain, but if dynamics change in somebody's life, I mean, probiotics, that's where they come into play. But how can we kind of use certain foods to try to encourage that good bacteria? And I think in general, we're kind of getting more towards, it's the vegetable department. I mean, we're even seeing that. I mean, the old food pyramid used to say fruits and vegetables. Now the new plate has them separated out, and the vegetables keep getting larger. And so I think that's what we're learning is that, okay, they're not replacements.
Yeah.
And so I think the vegetables are really being targeted as being, okay, this is probably one of the better things to grow that good microbiome in our mouth. And certainly, as we've kind of known for a lot of years, I mean, carrots, they're one of the number one, and it probably has something to do with the consistency of them. In addition to, there's even nitrates in carrots have been shown to grow good bacteria on your teeth. And so with my little guy, if he does have something, he has some fish crackers occasionally. I'm not saying he never has that, but I will actually reserve a few carrots for the end and have him eat carrots at the end.
Almost like brushing your teeth with carrots kind of thing?
And so just chewing through those things, even to the point when he was an infant, I would buy, you can even get shredded carrots and start really small. Just getting him used to that being kind of the standard. And certainly, like I said, in starting with those vegetables strong early, and then I went to slicing carrots, and then I went to, now it's whole carrots. He's 7 now, and certainly he's caught on to that in society. Snacks are quite variable, and so he'll even say, when I offer him a snack, he's like, "Is it a real snack or is it a dad snack?"
Yeah,
and so he's caught on that some people offer
real
a snack.
Real meaning not real. Yeah,
and that's probably in a package that you can leave in your car all year long, and it won't go bad, and it doesn't have to be refrigerated.
Yes.
And
the emergency hangry snack,
it's probably loaded full of sugar, which is
a preservative.
Preserve that. So, which that's a whole nother dynamic, is how we've shifted, because sodium has been kind of turned into something that's not good for us. High blood pressure, all these things. So we went down that path for so long. So what did the food industry do? We just started pouring more sugar in there because we have to preserve it somehow. And I think jerky is a great example. 25 years ago, I did kind of my own survey in stores to see where jerky was falling in. And we used to have beef jerky and beef jerky teriyaki.
Yep.
And that was the sugared. And beef jerky was still salted. Now you are hard-pressed to find jerky in the store that isn't sugared. Use brown sugar as the number 2 ingredient after the beef. So, yeah, it's just a shift in our dynamics, especially in our country. Everybody wants things sweeter, and so that's what's been shifted. And I think that decrease in that sodium as a preservative has been part of that puzzle as far as shifting those things.
Interesting. So I don't want to go too long. I know you have some stuff to do, but I guess other insights from your clinical experience, some take-home things that that maybe you just want to hammer home for parents. Would be one question I would have for you.
Yeah, and I think it's as your child ages. I mean, starting at those early ages, getting them started off on the right track, but then always kind of reevaluating things as time goes by, because as a parent now, I've started to realize how difficult that is. It's not it was much easier before I had a child, because I could just tell people exactly how they should do things, and
you
I felt
cast
good
judgment
when I went home.
from on high.
This is how it should be done. But now that I have a child, and now when I dropped him off at daycare, and I'm looking at those puffs that they're offering him that are all natural, and can he have some of those because I was bringing his food to the daycare, and having to unravel some of those dynamics. And I think it's part of it is like I said, as we age and we watch our children grow, it's always kind of reevaluating things and saying, okay, what has changed? Now, okay, we do maybe have different exposures, because we do know that once 3 meals a day, 2 snacks, brushing twice a day, that's kind of been felt like a balance. And when you think of it, and we often think of a snack, is that a volume, or is that a length of time? Because a bag of goldfish crackers could be not so risky if you eat it all at one time. A couple of crackers, drink some water with it.
Finish off with a couple carrots.
A couple carrots, sorry, not crackers. But that, certainly balances risk when you think of those things. But that same bag of goldfish crackers, nibbled on in the car seat for 2 hours of shopping, very different dynamic when it comes to the oral cavity. Because again, it's just
sticking on those teeth.
Yep, and you're just fertilizing that bacteria. The bacteria takes about 20 or 30 minutes to process the carbohydrate. Then it releases the acid. So 30 minutes later, it's ready for more. And so you put one more cracker in there, and all of a sudden
it's like stoking a fire.
Yep. And so it's just kind of growing that bacteria. And again, that's at those younger ages. But then as they get a little bit older, it's like, okay, do I need to start talking to teachers? Do I want them to have that M&M? Do I want them to have that kind of that? Because, again, it's that frequency that we're looking at, not necessarily a volume of things, but how frequent are we getting those things? And so you're just kind of always unraveling those things. And then, of course, we get into adolescence and then even teenage years, and pretty soon there's a few dollars in their pocket and they're making choices, and those are the challenges. And we can go into the whole, we have lots of coffee shops.
Oh, my God. Don't even get me started.
The
caramel mochiatas.
I mean, we're near one of the junior highs, and that place is packed with kids standing in the drive-through.
Yeah.
There'd be 20 of them standing around that window and walking away with something.
And some of these
bright
drinks have
green.
70 to 80 grams of added sugar.
It is
the upper limit recommendation for kids is 25 grams.
25 grams.
36 for adult males.
Yeah. Yeah. And
so you're tripling that just in that one drink.
Yeah. And so as these kids are aging, it's just that we just can't be, as long as we're brushing twice a day, we're going to be good. Mm-hmm. It just doesn't. That's just not the way our world is anymore. And I even have a conversation about cup holders in cars and how that has changed dynamics. Because my 1979 Oldsmobile Delta 88 had 0 cup holders. And now we have a fairly small SUV, and I think it has 9 cup holders, and there's only 5 seats. Yeah. So just things like that those dynamics change.
But it'll handle a big gulp.
It'll handle a big cup.
44 ounces of teeth-rotting pleasure.
Exactly.
So good. So what do you think the future of pediatric dentistry is? We kind of touched on this before, but like, what directions do you see kind of coming in on the horizon?
Yeah, I mean, I think it's always navigating, like I said, the nutritional piece of it, because that dynamic has certainly changed over the last 50 years dramatically, and then certainly, we have kind of different kind of things that are in our country that are controversial. I mean, you look at fluoride, which is no doubt about it. Fluoride has been the number one dynamic that has changed kind of dental disease in a good way. But, it's trying to unravel that and kind of what does current society, kind of want. I mean, certainly getting that fluoride against the teeth topically is certainly the most benefit. Ingested, there's some benefit there, but, then you have to balance those risks and those benefits. Mm-hmm. And so I think, as we unravel that in our country and kind of see, well, where is that going to go? I mean, certainly we are preparing ourselves as that if it seems like that's the direction the country chooses to go, we are going to see a huge uptick in cavities. And they've already seen it in places that water fluoridation was removed. I mean, Juneau, Alaska is certainly a fine example of that. Lots of data before when there was no fluoride, then fluoride was implemented, and now there's lots of data being developed after fluoride is removed from the water source. So those are things that we're kind of learning from. And certainly, where is the most benefit for fluoride? We do think it is topically.
Yeah.
Teeth. It's what's touching the tooth is the most amount of benefit.
So, fluoridated toothpaste then would be, the primary route, because then, especially when your kid's old enough to spit and not swallow that, you're not getting the systemic potential risks from it, but you're getting the topical benefit.
Yep. And really it comes down to concentration, because we can't ignore that. I mean, fluoride is a naturally occurring. I mean, I have fluoride in my well here in Kalispell. Mm-hmm. It's a pretty small amount, but we certainly have fluoride just found in well water, and that's where it was originally found anyway for as far as preventing cavities. And so, but on the other hand, certainly is too much a concern. There's no doubt about it.
Yeah.
I mean, and that's where a lot of this evidence has come from.
It's the neurotoxic effects at a high amounts.
Levels. Yep. And so that's
and it interferes with iodine, which you need for thyroid production. Yep. So there's some interesting data on that too. So
absolutely.
But if you're brushing and then spitting out the toothpaste, likelihood you're going to get to a toxic level from that is, I think, pretty low.
I mean, toxic level is certainly, and even, I started brushing my child with fluoride toothpaste as soon as he had a tooth. And it all depends on controlling how much you're putting on there. Mm-hmm. A tiny smear on there is appropriate for
eating a tube of toothpaste. Probably not.
Probably
not a good idea.
That's not what we're targeting. And then once you're spitting, really volume doesn't matter, but you don't need the big, huge swirl of toothpaste that just sells a lot of toothpaste. But certainly, but getting to that 2 minutes of it touching those teeth is a key element, though. That's not to be ignored, because, of course, my child would
the toothbrush timer.
Yep. Yeah, and that's what we kind of went to with my little guy. He's 7 now, and we went to a timer because, of course, he would brush.
Like, what is 2 minutes?
Exactly. And for me personally,
1, 2, done.
And for me, I can't stand there and look at myself in the mirror for 2 minutes. So I got to go let the dog
walk
out,
around, doing
spending
some stuff,
some time with that toothpaste in her mouth. So
awesome. Well, how do people find you?
So we're at Kalispell Kids and in Kalispell, Montana, and we have our website out there.
And then are you guys on socials at all, or not really?
So we have a little bit of social media, but we haven't really kind of delved into that quite a bit.
So yeah, just Google Kalispell Kids, KIDDS, or Dr. Reed Thompson, and you'll be able to find all your important stuff. But appreciate it. It was an awesome talk. I think
Awesome.
your parents will find this
Appreciate
really useful, so we'll have to have you back at some point. But if you like this, if you think it's useful, please share this, like it. Drop us a line here over at Functional Medicine Associates of Montana. You can get on our website. Or give us a call. And if you have any ideas for future podcasts, we'd also appreciate that too. And thanks for listening, and we'll see you next time.